morning. This is Dr. Deuk, and it's January 7th, 2020. January 7th, 2020. We're here at Deuk Spine Institute, Surgery Center of Viera, where we perform our surgeries. And this morning we're going to be performing a Deuk laser disc repair, bilateral, which means both sides, for a patient who has leg symptoms of pain, numbness, tingling in both legs, and has a herniated disc at L5S1. The herniated disc is on both sides, so it's irritating the L5 nerve root and the S1 nerve root on the left and right side. So we're going to get started. Good morning, sir. So it's Dr. Deuk, and we're going to get started here, okay? Now, in the beginning, I need you to lay still. You'll be awake for a few minutes, and then I'll put you to sleep, okay? Now, while you're awake, I want you to lay still and not move your body. If you feel pain, just say, ouch, I'll give you some numbing medicine, okay? Now, in the very beginning, you're going to feel a little discomfort as I numb your back up. Okay, that's just my finger touching you. But I'm going to give you a little injection in just a second. Okay, you'll feel a little stick and burn. And that's perfectly normal. Okay? So don't get bothered by it, just relax. That's just the numbing medicine, okay? And it's about to get better for you. Same thing on the other side. A little stick and burn. All right. So remember our deal. If you have pain, you just say ouch, and I'll give you some more numbing medicine, okay? All right. If you have questions, you're welcome to ask me as we get started as well. Otherwise, I'll be talking to our audience who's going to be listening. All right, very good. Now just relax. Has he gotten any fentanyl?
Oh, yes, he does. And he's been comfortable.
Shot? Good. All right. Everything's going good. I'll let you know if we have any problems, okay? Shot. Lateral. I don't expect any problems at all. And I'll just be talking to our viewers as we get started and get the surgery done. Alrighty. So. Huh? Shot? Just relax. Where'd you feel that? All right. I'll give you a chance to relax. Let's get a wag on the side view because I see too much obliqueness on the end plate. That's actually better, but we're too far south, so let's go north. Shot? Okay, that's good. Shot? Shot? AP? I'm going to have to start a little bit more medially. Let's just see where we are. Shot. Shot. Lateral. Shot. It's a little lower than I want to be. Shot. Where do you feel that?
Like down my left leg.
How far down?
That one only to my knee.
Okay. I think we're lined up pretty good on the end plate. So to the knee, shot. 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 Yeah. I'll have to change the trajectory a little bit. Shot. So right now we're getting right where the herniation is. I can feel it. AP. So the tip of the needle is right at the back of the disc. That's the L5S1 disc. It's named after the bones above and below the disc. It looks pretty good. Yeah. So I'm inside the disc at this point. Shot. Okay, good. All right. What's going on?
No, just put an instruction to.
All right, shot. Yeah. Give me an AP. So the Deuk laser disc repair is a very unique surgery. It's a type of endoscopic spine surgery, but it incorporates specific types of treatment that are not used in any other surgery in the world. Most notably, what distinguishes the Deuk laser disc repair from every other surgery is the annular debridement. That's basically going in and cleaning up the annulus fibrosus where the tear is. Where the tear in the annulus is where the herniation is. So the herniation is the jelly in the center of the disc that comes out through the tear. So the first thing that happens is patients will get a tear in their disc, in the annulus, which is the outer part of the disc, as a result of some trauma to the disc. It could be bending, twisting, lifting, a sports injury, a car accident, a fall. It could be something that happened many years ago. Shot. And is he doing okay?
Oh, yeah. That
Good.
was just
Shot.
telling him that there was bright light.
Okay. That's fine. Shot. Let's go lateral. What is wet here? Is that supposed to be?
Yeah.
So there's always a traumatic event that occurs in a person's life to their spine, to the disc. And you've got bones and you've got these soft discs, right? And so the bones are much harder to damage, much harder to hurt. Whereas discs are pretty easy to hurt. Unfortunately, discs are soft, shot. And so by being so soft, they're much easier to damage than bones. Typically, people get injuries to their disc much more common than they get injuries to their bones. So people that get injuries to the bones usually have a problem with the bone, shot. So the kind of problem I'm talking about would be like osteoporosis, osteopenia, shot. How you feeling? Shot? You feel that?
Yeah, this is good.
Where?
Down to my knee area and localized.
To your knee? All right. AP? That looks good. So basically, just stay there for a second.
Oh,
Where do you feel it?
pretty localized right now.
To your back? Shot? Yeah, we're at that bad disc right now.
Okay. Oh yeah.
Yeah. So we're going to be putting you to sleep in just a minute.
Okay.
How many of these surgeries have you watched online?
I watched like 5 or 6.
5 or 6. That's right. We talked about that.
Yeah.
And what did you think about it when you watched it online?
That was really interesting.
What struck you? By the way, for those of you watching, I'm having a conversation with the patient. He's right here on the table, and we're going to be putting him to sleep in a minute, but I'm asking him some questions before we put him to sleep. What struck you the most about the surgery? Like, what did you like? What did you not like?
I liked how you don't take out bone and how you basically seal up the ambulance there.
Yeah.
Um,
So what he said was he liked how this Deuk laser disc repair is the only surgery that fixes a disc that doesn't take bone out of the spine, and he's correct. Yeah, we don't remove any bone from the spine. We don't fuse. We don't put any metal or anything unnatural in the body at all. As a matter of fact, when we're done, you're just going to have your normal body minus the herniation and the annular tear. I mean, minus the inflammation in the annular tear. All right. Are you comfortable?
oh yeah.
Yeah, you're not going to like that.
Okay.
That's where we test the bad disc to see if it's the right one. And that was, how high was that pain for you?
Probably 8 or 9.
What's the highest it went to?
Oh, like 9.
9. All right. Is that where you typically feel your pain?
I'm not really feeling it down my legs, but yeah, that's
Yep.
yeah.
All right. But when you do get back pain, that's where it is?
Around that area. Yeah.
All right. Very good. So 9 concordant. At this point, what we've done is we've gained access through the foramen to the disc herniation on both sides because he has leg symptoms on both sides. So that's why we're going on both sides. Normally we just pick the side the patient has their leg symptoms on. Can you count from 1 to 100 out loud, please?
Sure.
Oh, not slow, slow.
You're fine. So most patients that come in have leg symptoms on one side or another. They don't have it on both. And but some patients do have it on both sides. And this patient has
Start from 1.
pain that goes down both legs. And the pain that went down both legs was, in my opinion, due to the nerves going down his legs being irritated and compressed by the herniation. So notice how I chose the words irritated and compressed. Irritated means the nerves are irritated, not from being compressed, but they were irritated from inflammation, a chemical reaction occurring on the surface of the nerve that causes symptoms to go down the nerve. And that results from inflammation in the disc and the annulus coming out onto the nerve root, which is right behind the annular tear and herniation. So, can you see, Sean?
Yes, we can.
All right, pretend this blue tube is the nerve, right? And it comes out of the hole in the back and it goes down to the leg. The disc is normally here, and when you get a herniation, it comes out and it can actually push on the nerve. All right, it can push on the nerve, and the other thing it can do is it can come close to the nerve, and the tear of the annulus is right here in the back of the disc herniation. That tear has inflammation going all the time. That's why people have back pain. That inflammation can leak out and get over the nerve root and cause inflammation of the nerve root. It's like putting bleach on your skin. It burns. And so this inflammatory stuff from the body burns the nerve root. So that's called irritation of the nerve root. So people get leg symptoms from either irritation of the nerve root or compression of the nerve root. So a herniated disc can compress the nerve root, or it can chemically irritate the nerve root. Some people have both. Some people have one. Some people have the other. So what I found in my practice with just treating people with herniated discs is that 95% of the time people have leg symptoms from irritation of the nerve. That's why they're missed and not treated by most surgeons, because surgeons are looking for compression of the nerve, something squashing the nerve, a big piece of disc herniation. And most patients don't have that. So a lot of people are living with back pain, leg pain, because their doctor doesn't recognize the fact that the nerve can be irritated from the herniation, not just compressed. And that's the truth of 2020 and everything before this. That's how I was taught as a resident in neurosurgery, but that's wrong. And it needs to change. And that's why we air these videos, so we can change the way the world sees back pain, neck pain, herniated discs, and inflammation of nerve roots. It's fixable, completely curable with this surgery, the Deuk laser disc repair. This is the surgery to treat inflammation of the nerves by a herniation, annular tear, and you don't have to have compression of the nerve to get the surgery done, whereas other surgeons will tell you you need compression. How's our blood pressure?
Blood pressure is, let's see, give me one check. It's 110 right now.
110's okay. If you can bring it down just a little bit more. All right, so we're going to make our first incision. Remember, we're treating L5S1. So the incision is 7 millimeters. That's how tiny this incision is. This is where the endoscopic part of the surgery comes in. Now, this is what I was taught overseas about 13 years ago, almost 14 years ago now. I was taught by a group of surgeons from around the world, specifically South Korea, Germany, and the United States. There was one surgeon in the United States that helped me the most. That was Dr. Anthony Young, Tony Young. He's a pioneer in endoscopic spine surgery in the back. For the cervical spine, for the neck, I had to learn pretty much from the South Koreans. All right, drop the fluoro if you can. If you can't drop the fluoro, then bring the table up about an inch.
Table up,
So during the surgery, the audience, are allowed to ask me questions. We encourage you. Get a shot? We encourage you. She already brought it up. Did you bring it up evenly, or did you bring just the feet up? Shot? Yeah. It seems like it's up too high, guys. You guys brought it up way too high.
table up.
No, down.
Okay, sorry.
You went up too much. Stop.
Stop.
Shot.
Wait, stop. Take that area, see? Right here.
Too high still. Drop it.
High still, okay, dropping.
Shot. No, stop bringing it down. It's just a little bit. It's little movements. It's not the full height up and down, okay? Shot. This is not like a a procedure where you're either very high or very low. There's little areas in between we need you to be. That's actually really good right there. I'm happy with that. Thank you. All right, so we've made our incision. We're now bringing the dilator down through the tissues to create a path. And this dilator is so skinny, it's 6 millimeters, shot, that it's not going to damage anything. It's only going to spread the muscles and fascia. Okay? So we're not cutting muscle, we're not cutting fascia, we're not cutting anything. We're just passing through by spreading. Spreading. Kind of like if you take your hand in the sand on the beach and you push it down through the sand moves around your hand. You're not actually cutting sand particles, you're just spreading them. And then when you take your hand out, yeah, that's painful. That's because we're in the painful disc. All right, give me an AP. One thing I can see from this patient is that this patient does have short pedicles. They were born with short pedicles. So 20% of the general population of the world has short pedicles, which are a piece of bone that juts out the back of the spine. Good, go back to a lateral. And that piece of bone determines the natural size of the hole where the nerves come out, called the neuroforamen. And when you have short pedicles that you're born with, then that disc herniation is very close to the nerve root to begin with in your life. Okay, he's moving a little bit. Shot. Maybe some fentanyl. Just a little bit would be fine. At this point, we're in the safe zone. All right, so I have to now advance the dilator into the disc through the tear. And he has a tear on the left and right side both. Shot? Yep. All right, so I've started the dilator in the disc. I can take out the guide wire and I can advance it further, shot, by just holding it and directing it. So what we've done so far, we haven't really done our discectomy yet or our annular debridement. All we've done is gain access to the disc, exactly where the herniation is, without removing any bone, without making an open incision. You all can see the midline right here. This is the middle of the back. We drew a line on there to help orient me. And we've come from the side. Traditional back surgery is done through the back or through the belly or from the very far side. But this is a very unique approach to the spine, going through a natural opening that's already in the spine called the neuroforamen. That's the hole I was telling you about that we're passing through to get to the disc. That hole in this patient happens to be narrower than normal because of the short pedicles. So when you see short pedicles, it could indicate that the patient will have small herniations that cause a lot of symptoms because the back of the disc is so close to the nerve root to begin with. A lot of surgeons don't think about this stuff, folks. This is just kind of high-level thinking, and I'm sharing it with you because I'm sharing everything I can through these video presentations, through these broadcasts. Now, you're watching a live broadcast if you're watching today, which is the 7th of January 2020. We're in the east coast of the United States. We're located in Florida where NASA is. We're about 10 minutes from NASA. And it's 9 o'clock in the morning. So if you're watching right now, then you're watching a live stream. You're welcome to post a question and ask me a question during surgery. This that I'm holding in my hand is the tube that we're going to do the whole surgery for. This is the Deuk laser disc repair procedure. Can only be done at Deuk Spine Institute here in Florida. And the whole surgery is done through this tiny little tube. It looks like a metal straw. I call it my shake straw. All right, so now that I've put the dilator in and I've spread the tissues, I'm going to bring this tubular retractor down through the incision, and I'm going to bring it into the disc itself, right through the annular tear. And by going through the annular tear, I can take the herniation out, and I can also debride the annular tear with my laser. And it's the annular debridement that's the most important part of the surgery that I spend the most time on, that no other surgery in the world has other than the Deuk laser disc repair. Now in the future, other surgeries may have it because they'll be copying what I do, which is what I hope that happens, because the annular debridement is the most important part of the surgery for eliminating pain. And it's what most other surgeons don't do. It's what other surgeons don't do, which is why it's rare for back surgery to fix people's pain, because the surgeons don't do an annular debridement. Most surgeons won't operate for pain because they can't fix the pain because they don't do the annular debridement. All right. Any questions from our audience, Sean?
We do have one that was submitted through the app.
Great. Oh, yeah. Before I take the question, let me give a little plug. So, again, I'm Dr. R. Deuk Majan, CEO and founder of Deuk Spine Institute. You're watching a Deuk laser disc repair. And Deuk Spine Institute created a spine app that's free. It's available on iOS, your Apple platform, and it's also available on Android. So it's available to anybody that has access to an app store, and it's free. We don't charge. And it's literally probably the best spine app you'll see out there. We've had a lot of downloads already of the app, and people are using it. But you can actually watch the surgery, and you can also ask questions. And there's a lot of resources with testimonials and people who have gone through surgery. Okay? I'll take the question in just a minute, but I want to tell you where we are. So we're looking through the camera and through the endoscope, and what you're seeing, guys and gals, is the inside of the disc, the inside of the herniated disc. And we're on the patient's left side. And so you can see the blue stuff down there is the herniated nucleus pulposus, which is the center of the disc, the jelly that's herniated, and the white stuff is the annulus. And so we're going to remove some of these herniated fragments using a grabber. We call it a pituitary rongeur. Okay? And then once I do that, you can see that the pituitary rongeur is not very effective at removing the herniation. Okay? That's because the herniation is stuck down to the annulus. All right? It's stuck. What's wrong? Everything okay? Do you want me to wait or keep going? Everything's good? All right. So I've got the laser in there, and people laugh at using a laser in spine surgery, but I got to be honest with you. When I first heard about it, I kind of laughed too. I just jumped on board. This was about 20 years ago. And then once I actually learned how to use a laser in spine surgery, I realized how valuable of a tool it is. It can do things that no other instrument can do. So all the other surgeons that don't use the laser to repair the disc like this are actually missing out on a very valuable tool that could be used to help them treat a problem in the disc. And the reason is that there's so little space to work in inside this tube. By the way, that's the tear right there, the blue crack. And it's going to become more obvious to you as I start to move more towards the periphery of the disc and get towards the foramen. All right, so I know we have a question from the audience.
Yes, a question submitted over the app. One of
Through
our
our
viewers, they say that they had an MRI done and it showed an incomplete tear in the spinal cord. Their surgeon told them that it could not be fixed. What else can they do?
So one of our viewers had an MRI done that showed a tear in their spinal cord. So the spinal cord is very different than the disc. We're operating on the disc, a disc herniation. If there is a tear in the spinal cord, I would like to know a little bit more about what kind of tear it is. There's only two things that come to mind. One would be a traumatic injury to the spinal cord from a car accident or a fall where there's a fracture of the spine and the spinal cord has been damaged severely. Come on, Luis. You got to do a better job than that. The other thing that could happen is that it could be a syrinx. All right? A syrinx is actually a fluid-filled space within the spinal cord. So I don't know which of those they have, if either. But a syrinx, if it's not causing problems, doesn't need to be treated. And maybe that's what the surgeon is saying. I don't know. But a injury to the spinal cord from a fracture of the spine is is not something that can be fixed with surgery either. Now, some syrinxes do need to be fixed surgically, either drained or there's a tumor associated with them and it needs to be removed. But we don't have enough information from our viewer to be able to intelligently answer this question. So I need additional information. If you want, you're welcome to submit your MRI for a review. I can do a online review for free and look at your MRI. And I'm happy to do that for anybody out there that wants an opinion from an experienced spine surgeon. Dr. Deuk, that's me. If you want my opinion on your spine, whether it can be fixed, how it can be fixed, what the likelihood of eliminating your symptoms would be, how safe is it, I can have that discussion with you, no problem. We do MRI reviews for free, and if you don't have an MRI and you have a CAT scan, that's fine too. We can do a CAT scan review. But that's what we do. We do free MRI reviews, free CAT scan reviews. All right, this is the herniation right here. And the blue stuff is the nucleus. It's degenerated disc. It's the nuclear material that's been basically herniated out. And there's a lot of scar tissue. You see all this stuff? This should be going away quickly with the laser. If it was normal disc, it would vaporize quickly. But it's just so scarred right here. And that scar tissue is from inflammation. So the disc, when it was injured in this patient, and every patient, it gets inflamed. Just like a pimple on your face. A pimple is inflamed, is an inflamed follicle. Okay? Follicle is a little crypt, a little like a little tunnel or cave, better yet, cave in your skin. If you get bacteria trapped in there, it creates an infection. The infection creates inflammation. So the inflammation causes pain, tenderness, swelling, redness. That's why pimples are red and tender and swollen, and they're warm because they have a lot of blood supply to them. So that's no different than this herniation right here, except that there's no bacteria involved in a herniation, okay? It's just inflammation. And the inflammation is due to the nucleus pulposus, the stuff in the middle of the disc, squeezing out through the tear in the annulus fibrosus, the outer part. And when that nucleus squeezes out into the outer annulus, it elicits an inflammatory reaction in the outer annulus because the outer annulus actually has a blood supply, unlike the inner annulus, which does not. So small herniations like grade 1 or 2 herniations do not create pain because they don't create inflammation. But when the tear goes all the way through the disc, from the inside to the outside, it becomes a grade 3 tear, and you can get inflammation. And the inflammation comes literally from the outer half of the annulus, which has a blood supply, and it gets inflamed because the nucleus pulposus material is seen by the blood supply and the inflammatory cells that are carried in the blood supply, such as polymorphonucleosides. And those PMNs, or neutrophils they're called, elicit an inflammatory chain reaction. And then you get macrophages, you get other inflammatory cells, and then you get scar tissue. So this whole pain from a herniated disc is misunderstood by the entire world. And I'm trying to re-educate everyone to what it really is. But if you talk to spine surgeons around the world, they'll tell you that they care about herniations because they put pressure on nerves or spinal cord. But the fact is that 90% of patients with symptoms from a herniated disc don't necessarily have compression of the spinal cord or nerves. They just have irritation through inflammation. So it's the big missing link in understanding back and neck pain is inflammation. And it's ignored by neurosurgeons and orthopedic spine surgeons all over the world. I mean, chiropractors have a better understanding of the causes of back pain than neurosurgeons do, and orthopedic surgeons do. Many times orthopedic surgeons understand back pain from a herniated disc better than neurosurgeons do. But I think neurosurgeons are better qualified to treat it, but they're just ignoring it. They're ignoring it because they're not taught in their residency programs by their attendings how important inflammation is in the pathophysiology of chronic spine pain, chronic neck pain, and chronic back pain. Inflammation is 100% the cause. So we ignore inflammation as spine surgeons, not me. I learned to respect it and treat it. But everyone else ignores it, and that's why there's so many patients around the world that have chronic pain because their doctors don't understand the role that inflammation that the patient's having in their back or neck from the herniated disc. They don't understand how important it is to treat it, to fix it, because they don't understand that that's where the pain's coming from. It's incredible how simple it really is, and yet so elusive to thousands and thousands of doctors and patients. So that's why we bring these broadcasts to you, the general public, because the general public could be nurses, doctors, it could be people suffering from chronic back or neck pain, but in the end, if we don't talk about it, no one's going to know about it. And if nobody knows about it, that would be a shame, because it's entirely fixable with the right surgery. And the right surgery is the surgery you're watching right now, the Deuk laser disc repair.
We have another couple questions.
Sure, we'll take the questions.
One of our viewers from Facebook asks, are there any disc-related conditions so bad that you cannot operate on them? And if so, what is the alternative?
So the question comes from one of our viewers, Dr. Deuk, are there any disc-related conditions that would be so bad that you could not operate on them? And if so, what would they be? So let me answer that question. There are no disc-related conditions that are so bad that we can't operate on them. Okay, that's number one. We can fix them. But there are some disc-related conditions that I cannot fix with laser surgery. Okay, so I may not be able to do this treatment. For example, if somebody has, and it's not really a disc-related condition, but it is related to the disc. It's called a spondylolisthesis, grade 3 or 4. If they have that, where the bones of their spine are slipping so badly that their spine is basically slipping off their pelvis, then we can't do the laser surgery for that. That would require screws and rods, open surgery, okay? But that's so rare. That's like 1 in 100,000 cases, so it's rare. But 95% of herniated disc can be fixed with the Deuk laser disc repair. The surgery you're watching now, endoscopic surgery with an annular debridement, 95%. Now, the 5% that can't are going to be things where there's deformity, okay, associated. So if you're talking about just a disc problem without deformity of the spine, then they can all be fixed with Deuk laser disc repair. But if you're talking about other things like kyphosis, really bad scoliosis, or listhesis, which is slippage of the bones in different planes, those types of problems may require open surgery with a fusion, okay? Another one that comes up from time to time that I see that I cannot fix with the laser surgery that I'm doing is a synovial cyst, but it's not really a disc problem. Okay, it's a problem with the facet joint. All right, we're just about done with this side. You can see at 12 o'clock the epidural space, and I just want to make sure that we get everything here done. Our patient is snoring blissfully. Either that or my nurses. I could hear it in my ear. All right, what's the next question there, Sean?
Our next question comes from a viewer on Twitter who asks, are there any proactive exercises or things that we can do to help lower back pain and avoid needing surgery?
All right, so are there any proactive exercises or things that we can do to avoid lower back pain and needing surgery? That's a great question. I thank you for asking. The answer is yes, absolutely. So I want to make sure we're clear. Chronic back pain has several different causes, okay? And the most important and the most common cause has to do with arthritis in a joint called the facet joint, F-A-C-E-T, okay? So there are two types of joints in the spine. There's a facet joint and there's the disc joint. We're operating on the disc joint. The facet joints account for about 80% of chronic pain, 80%. So 80% of pain that patients have in their back for a long time, it comes from arthritis or inflammation within the facet joint or joints. It could be multiple joints. So if you look at a spine model on the internet, you can look up facet joint, F-A-C-E-T joint, and the facet joints account for 80% of chronic back pain through inflammation within the joint. Those patients, about 80% of them can have a procedure called a rhizotomy, and that will cure their back pain. And it's not a surgery really, it's just a needle procedure. Okay, it's where we go in and we zap their pain nerve and get rid of their chronic back pain. So 20% of patients with chronic pain in their spine comes from the disc herniation. And the surgery you're watching right now, and most surgeries are done for problems with the disc, pain coming from a disc, okay? So to break it down, if patients have chronic back pain, it's most likely they're having it from a joint called the facet joint, and they don't even need surgery. They just need a therapy, physiotherapy, special exercises, and a rhizotomy, okay? Those two things, and that should fix the problem. Now, some patients with facet pain will not get better with the rhizotomy, and they will not get better with therapy and a rhizotomy. And that's about 20% of them. So 80% will, 20% won't. The 20% that don't will end up needing spine surgery. Generally, they're going to need a fusion if they have facet pain. Okay? Now, of the people with chronic back or neck pain, 20% of them, it's coming from a herniated disc. And that's the ones that the Deuk laser disc repair would work very well for. Now, for those people who don't have any pain at all, I mean, staying active is probably the most important thing you can do. Stretching, daily stretching, and exercise, whether it's walking, jogging, running, some type of a, or trekking.
Crystal, watch this ball, please. Make sure it's done.
What's trekking? Trekking means walking through the hills, mountains. That's probably the best exercise you can do. Climbing Mount Kilimanjaro in Africa. By the way, I got to tell you a funny story, Dr. Calcarney.
Yes, sir.
I was in the mountains with my family, my brother-in-law Brent, and he said to me, "Hey, what do you think about next year? Not going to the mountains, but not going to Utah, but going to Africa." And I said, "Yeah, I really want to go to Africa." And he said, "How about if we climb Mount Kilimanjaro?" And I said, "Yes, I want to do it.
You should.
I would love to." And
Personal trainer and
what do you mean personal trainer? I don't need a personal trainer. I'm an epitome of male shapeliness,
okay.
fitness.
No, they will, get you really working properly and one-on-one results.
Personal trainer, one-on-one. Does your husband know about this?
I have actually, $90 per session.
$90 for a personal trainer is what you pay?
Per session.
No, I wouldn't do that. I already know what I need to do.
No,
I understand, and I agree with you, but I'm not somebody who needs a personal trainer. Standby laser.
Okay.
Believe it or not, I was an athlete at one point.
So
Hard to
for
believe.
Kilimanjaro, and I will recommend the best, Thompson Safari.
Thompson's.
Yes, out of
Yeah, that's what I need to know.
Boston.
As a matter of fact, I think that's what he had.
Oh,
He
okay.
showed me Thompson Safari.
Oh, it's fantastic. They
Yeah.
are the best in the Kilimanjaro. They do that exclusively.
How's the sleeping accommodations?
Oh, I had an expedition tent with cot and everything.
With cotton?
Cot,
Cot.
cot and mattress.
Like
Cot, C-O-T, cot. What do you call the cot?
a cot. Yeah.
You know, the raised,
Yeah, off the floor.
okay, off the floor.
So you don't get bitten by bugs
And
and
they
snakes.
cook food fresh.
The what? They cook food fresh?
Hot.
What kind of food?
Anything you want, veg, non-veg, roti, Indian bread, whatever you want.
No way.
Yes, sir.
You pre-order it?
The day before, and there are 46 porters
40,
for 7 climbers.
46 porters. I feel like I'm supporting the whole country.
They are a little bit, than other. You can go with, you need extraordinary. You can go one, actually Justin Timberlake went with them.
Justin Timberlake did it?
Yeah, several years ago now. I know the exact guide you want to have, so.
All right, well, I'll be talking to you before we make any definitive
You can
plans.
take me as a guide, free.
But you've only done it once.
I want to do it again. There are like 5 or 6 different routes.
I know, but if there's a problem, why would, I mean, you wouldn't know what to do.
Well, with
You could intubate me,
yeah,
right?
correct. So you need an anesthesiologist.
Have you heard of those anesthesiologists that go around in the party mobiles?
No.
Yeah, they actually, you could rent them. If you have like a bachelor party or something, they have a vehicle that, all right, got to get that headlight out of my eye. They have a vehicle with IV bags, IV kits, and yeah, my brother actually, I'm ashamed to say this, but he had them for his bachelor party.
And then what do? Anesthetize?
What do you think they do? If you've been drinking heavily, they put an IV, they rehydrate you so you don't have a hangover.
That's a good way, safe way.
Yeah, I guess so, or just don't drink.
So how much anesthesiologists are paid?
How much do they pay for the service?
Yeah.
I have no idea. You got to look it up. I don't know. I've never hired them. No, but you don't have to drink. You're the anesthesiologist.
He's the first one to go.
I just don't like people drinking.
You don't like people drinking. I know. It bothers me too, but it's the reality of our society.
So this is still number 1, right?
Disc number 1. All right, sorry, Sean. We got sidetracked talking about Mount Kilimanjaro.
My fault.
No, it's okay. I enjoyed it. But I'm on the job, so I have to educate while I'm here. What's the next question?
We actually don't have any other questions currently.
Oh, so we can keep talking about Mount Kilimanjaro and anesthesia services for drunk people. Think about it, right? You have all these people who get drunk on the weekend and they go to the emergency room, right?
No, this is good because they can be,
Stand by.
their airway can be secured quickly before they throw up.
Right.
Lights on, please.
I knew you would see the good.
I want the maximum payment for that.
I think they get like $300, $400 an hour. That's what I would charge. Lawyers get paid $500. So you want to be paid what a lawyer's paid?
Yeah.
Hey, listen, here's my thought. How much is a human life worth, right? You're saving their life.
Life is very,
All right, so we're done with the first disc. That's the L5S1 left side. Okay, so we're done. And we're taking the tube out. And next we're going to go to the opposite side, which is the patient's right side. And we're going to do that disc herniation over there. So,
So, remember when you switch over here to the pedal, this way, okay?
go ahead and put some pressure here. So we always want to put pressure on the paraspinous muscle so you don't get any bleeding or minimize the amount of bleeding in the muscle, if there is any. Where's our blood pressure?
117, but I
No, we need to get it, I told you, we need to get it systolic below 100. Okay? Please work on it. I want systolic 90, 95. I don't want it at 117.
between 100
Yeah, no.
Pressure.
Give me 1 second, doctor.
Is that mine? That's loud. All right.
1 second.
Just take your time.
Anesthesiologist's job is very critical for heat sedation. I know you appreciate that, and that's why I like to work with you.
All right, so this would be a great time for our viewers to ask questions of the surgeon as I'm waiting. The scope should be off. Who's in charge of the scope?
Right, stand by, right here, stand by lights.
So,
There you go.
yeah, something you need to pay attention to. If I have the scope out, light is off. Okay? We shouldn't have to tell you. I need my tape pushed on my mask towards my nose. Are your gloves clean?
Yes, sir.
All right, so the right side. Nope, towards the nose. There you go, right there. Push it against my skin. There we go. It's created a steam vent. It's allowing the steam from my mouth to go up to my glasses and fog up my glasses. One of the issues surgeons have that wear glasses is that we can steam up our glasses and we can't see anything. So when we put our masks on our face, we have to put a tape to block the steam from going up to the glasses and fogging them up. Just thought I'd share that with you. Any aspiring surgeons out there? How are we doing? Can I proceed?
Yeah.
Are you sure? I can wait a little bit.
Go ahead, I'm fine. I just waiting something.
I'll just wait.
He's just not.
It's okay. I'll wait. All right. So we finished one disc, and I feel pretty happy about it. What we found in there was a tear in the annulus with a herniated disc. The nuclear material was blue. We zapped it away. We zapped the annular tear away. We got rid of all the scar tissue in the disc that was right around the nerve root. And I feel that the nerve root is now going to be decompressed and the annulus will be able to heal, keep the pressure until we get the blood pressure down. Now we're going to go for the patient's right side. Notice how I've already placed the needle transforaminal into the disc herniation. So at this point we're going to remove the needle because we have the guide wire through the needle. Are you rechecking blood pressure?
Yeah, well, just give me 1 second. I'm just suctioning it.
That's fine. Keep the pressure. You can lean into it. All right. So We've got our guide wire down. I'm going to go ahead and start backing the needle out. Shot. All right, you can see the needle and the guide wire. The guide wire is in the middle of the disc. The needle is now by the foramen. Shot. Yep, we're out in the foramen with the needle tip. You don't want to accidentally pull your guide wire out. Where's our blood pressure?
It just not, I mean, I'm being so aggressive, it just not coming down. Are you okay at the site?
No, no, we're not.
Like
Okay.
massive doses of,
No. Uh,
I can try some more.
it's okay. If we stay here longer, it's on you, not me.
Okay. Can I have a 100 cc bag, please? Yes.
How about fentanyl?
I did. Fentanyl, lots of labetalol, hydrazine.
How long ago with the fentanyl?
What's that just now?
All right, that's good.
He's actually.
Look at the difference that makes. No bleeding here at all. Look,
All right.
okay?
Hey, Doc.
That's what I just said. Look at what the difference 102 makes.
Thank you, Doc.
No, thank you. Just keep him around low hundreds or 90s. I'd rather at 90.
I want to keep you happy, so
Huh?
I want to make sure you get the ideal.
I like that.
Ideal.
I like that. You're saying you want to make me happy because you know what makes me happy is when the patient is doing good.
Correct.
You and I are the same.
Yes, sir.
We're happy when the patient's good. When the patient's doing really good. I've got it. The happiness for us is the success of our treatments. That's a
what
sign
you
of a...
remember about me, right, from before?
Of course I remember that. I know that about you. The same as my father. My father was happy when his patients did well.
And I was a pain in the neck sometimes.
Shot. You didn't bother me. You bothered everybody else.
Everything?
I'm just kidding.
Only
Of course I do.
Only when it came to patients. I don't know if you know, I used to buy pastries and everything for residents.
No, I never got any of those pastries.
When they worked hard.
That's good. You're a smart woman.
But whoever didn't work hard, I didn't let them do it.
You what?
I didn't let them. I came 5 o'clock in the morning, saw patients the night before. The residents who weren't prepared for the case
Yeah.
come 10 minutes before,
Yes.
vascular or cardiac.
Yes.
I wouldn't let them. I would go ahead and do it myself.
Oh,
They need to learn. That they need to know their patients, right?
of course. So you're saying if the residents weren't prepared, you didn't let them do the case?
I mean,
Shot.
because there was so much pressure from surgeons.
Yeah, of course.
Of course.
Residents should be prepared, Shot.
Yeah.
If they're not prepared, they either don't know they need to be prepared or they don't care.
Hey, Crystal. Yeah. Do you mind drawing some profiles
Shot.
for me, please?
All right, so we brought our dilator now down to the other side through the incision. And we are going to bring our tube. So we did the whole surgery on the other side through this tube. You all see that there, Sean?
Yes, we do.
You see the tube? We go right through here. We're bringing that down over the dilator now on the patient's right side. Remember, we're going through a natural opening in the spine called the neuroforamen. And this technique of passing through the neuroforamen from outside to inside towards the disc is called transforaminal. Trans because it's trans across, okay? And foramen because it's the neuroforamen. You all heard of the Trans-Siberian, right? They went across Siberia. Trans just means to cross or pass through. Shot, that's it? Is that it?
Yes, sir.
All right, looks good. We're going to get the dilator out. Luis had a good idea that it was going to be not so easy for me. Shot. Okay. So now the dilator is stuck to the tubular retractor. They want to move as one. So before I do anything here, I'm going to put my guide wire back in because I'm having trouble separating the two. Okay? There must be a piece of tissue in there. Shot? Yeah, there must be a piece of tissue in there. That's not working. Shot. All right. Yeah, it's not that I can't get this out because it's stuck in the disc. It's not stuck in the disc. It's stuck in the it's stuck in the tubular retractor. You understand?
Yes, sir.
That's the whole problem. Oh, may have gotten it right there. Okay, good. I got a little loose there. Shot, I think. Yep. So what sometimes happens is a little piece of disc material gets wedged between the dilator shot and the tubular retractor. And what that does is it makes the two of them become one. Yeah, let me try that. I think that's a good idea. It's kind of what I was thinking too. But I have a feeling they're going to advance together. Shot? Yep. Luis has gotten really good at understanding what we're trying to do here. That comes with experience and intelligence and desire. It's true of anything you do in life. If you want to be the best, you have to have experience, desire, and intelligence. All three. Must be a piece of disc material really stuck in that tube. Shot? Alright, so we've got our tubular retractor left. We've got our dilator that desperately needs a cleaning. And we are ready to rock and roll, folks. So our tubular retractor is in position, and we're going to move the fluoro out. I'm putting the fluid adapter on. And now I'm going to bring the scope in. I'll probably need a little bit more room. I think that's... Can you pull that back further, Jordan? Just make sure it's not caught on anything. No. You're arcing. Unarc. There you go. Now bring it back. Or rotate it out. Scope is on. Good. I need more room. Good. There we go. All right. Perfect. Perfect. Okay. We're ready to get started. And again, this is the same disc that we were working on before, but this time we're approaching it through the opposite side. Through the opposite side of the back of the disc. This is where the other herniation is. Remember what I told you earlier. Most people, here's the herniation right there. It's a piece of it. Most people have herniation on one side that's symptomatic. You may find that as much as 75% of patients with a herniated disc and symptoms from that disc will have not just the herniation on the side that they have leg or arm symptoms, but they have a herniation on the opposite side as well. Okay, but they don't have symptoms on the opposite side. So generally we don't treat the opposite side if they don't have symptoms. So, but some patients will have symptoms on both sides from a herniated disc on both sides. And that's where the clinical judgment comes in, folks. That's where really, that's really where the expertise, the knowledge, the understanding, all that comes into play for your surgeon to make the decision of what is the right treatment for your problem. So this patient, I think, has tried to get care elsewhere and was either blown off and told that there's nothing wrong, you know, because his herniation at L5S1 on both sides is definitely there, and it's easy to see, but the surgeons he saw said, you know what, it's not big enough, it's not really pushing on the nerves bad enough to need surgery. So just live in pain. And for anybody that lives in chronic back pain or chronic leg pain from a irritated or pinched nerve, they know you can't live with that pain. You can't live a normal life. And I think it's incredibly selfish of doctors to tell people to live in pain. I would never, ever tell a patient to live in pain. You know, I think that's wrong. And doctors shouldn't do that. And that's something that has to change when it comes to back pain. Patients don't need to live with pain anymore. We can fix it. Now maybe, you know, you don't have a doctor or a place near you that can fix your pain, but Deuk Spine Institute can. And when I say fix, our average relief of pain in the back or neck is 95% after surgery. 95%. Wipe. Back on. So 95% relief of pain on average is massive. It's great. It's basically a cure. Okay? 1/3 of the patients having this surgery you're watching right now are cured of their pain. I think that's an old number. I think it's even higher now. I think it's closer to a half. That's a piece of herniation right there I'm zapping away. Okay? How did it end up back in the disc? Well, remember we shoved that metal dilator in through the tear, through the herniation, and we basically shoved the herniation back into the disc. So basically we made this a much safer surgery for the patient by pushing the herniation back into their disc and taking it out from inside the disc, because now it's not near the nerve root anymore. So you're not going to injure the nerve root while you're working on it. It's really brilliant, and that's not my idea. I give credit where credit's due. That's Dr. Tony Young, Anthony Young, who taught me that. Dr. Young pioneered what's called the inside out technique. Inside out, where you start inside the disc and you work your way out. And I learned that from Dr. Young. And there are other surgeons that do endoscopic spine surgery that do an outside in technique. I won't name names, but their results are far worse. Their complication rates are much higher. And they start in the foramen and work their way down to the disc herniation. Very bad idea in my opinion. And even the best of them, the very best, who practiced in England when he did practice, I think he's retired. Anyway, that doctor went outside in and had a much higher complication rate. His complication rate of nerve damage was around 10%. Okay?
We have another question.
Yeah. At Deuk Spine Institute, our complication rate of nerve damage is 0. In 1,000 surgeries, there have been 0 nerve damages, 0 complications at all, 0 infections, 0 complications with laser surgery, Deuk laser disc repair. Yes, I'll take the question.
One of our viewers on Facebook is wondering, how do you monitor the amount of radiation you and your team are exposed to over time?
Great question. So one of our viewers is very astute and asked, how do you monitor the amount of radiation that you and your staff are exposed to over time? So why is it important that we monitor how much radiation healthcare providers are exposed to? Anybody know the answer? It's a very simple answer. The answer is that the effects of radiation on DNA of cells is cumulative. Cumulative. That's a very special word. It means that the cells don't heal. The damage done by radiation does not heal ever. It's just added onto the next time. So imagine if you were a professional boxer and you came out of the ring and you had bleeding over your eye, cut over your eye so you couldn't see, and you had a swollen face, and that never went away. And you went to the rest of your life, and you went to your next boxing match, and you always started at a disadvantage because you have all these injuries to your face that never heal. That's what radiation is like. It never heals. The damage done today will be the same tomorrow, the next day, and it never heals. So the cumulative effect of radiation is very important to healthcare providers, particularly, and sometimes even to patients who get a lot of radiation exposure. So how do we monitor that? How do we control it? Well, the most important thing, in my opinion, is to avoid exposure to radiation as much as possible. So what I developed very early on in my career was an awareness and a vigilance and basically hatred for radiation, except for obviously the fact that it helps you figure out where you are in spine surgery, which you need. So I've always done everything I can to minimize exposure to radiation for me, myself, my patients, and my staff. So how do you do that? Well, basically there's several things you can do. One, you can use a special mode on the more expensive, better fluoro machines called pulse, P-U-L-S-E, pulse. And what it means is rather than emitting a continuous beam of radiation while it's on, it actually pulses the radiation. So for every second of radiation, there's about a third of the time is no radiation. So it pulses the beam, okay? So it actually reduces the radiation by about a third. The other thing I do is I just take pictures with the X-ray machine and give radiation only when absolutely necessary. Some doctors, most doctors, to be honest with you, have no sense of how dangerous the radiation they're getting exposed to is. They don't care. I went through my residency and training, and it's like nobody really cared about radiation. You talk to interventional cardiologists, they really don't even think about it. They're just so exposed to radiation every day. Sure, we wear protective gear. We wear lead aprons. We wear lead chests, lead thyroid shields. You can even wear glasses that protect your eyes from radiation, because people can get cataracts from radiation, okay? So we protect the patient by having radiation shields that we put in place around the bed that block radiation to areas that don't need to be exposed. We protect all of our staff in the operating room, everybody in here. If you could look around, maybe you should take a quick look, and you can see that we have lead on, right? You want to show us your lead? Anyway, we wear lead. Okay? So the other thing we have, besides protection from radiation, to be able to quantify how much radiation exposure we actually have, is everybody has a little name tag on a radiation sensor. And every month those radiation sensors are collected and we send them out, and the company then comes back with a report about how much radiation we've gotten for that month. And we keep track of it and make sure that the levels are not too high. Okay? So, number one, we are very hyper aware of the dangers of radiation, and we minimize the exposure to everyone, the surgeon, the staff, and the patient, by using as little radiation as possible. It's really up to the surgeon. The surgeon has to prescribe the radiation during surgery. So when I say fluoro, I'm actually prescribing a dose of radiation. And it has to be done by a licensed healthcare provider with privileges to do so. At the surgery center where we work here at Deuk Spine Institute, the surgeon has the ability to prescribe that radiation, and so does the PAs and nurse practitioners that work in the operating room, okay? So, number one, control the amount of radiation and limit it and minimize it to the least amount possible. That truly is, If you ask 70% of surgeons about radiation, they're like, oh, I don't know, I don't care. I don't really pay attention. But the reality is you have to pay attention because it's dangerous. And radiation can cause all kinds of problems. So I've always taken it very serious, even as a resident in training. Even when my attendings never took it serious, I took it serious. Okay? We used to have people who would literally work with the x-ray machine getting radiation and not even wearing lead or protection. It was crazy. And they don't understand how dangerous radiation is because you can't see radiation. You can't feel radiation. It doesn't hurt you right away. It causes cancer and it causes cataracts. And it damages your thyroid and causes thyroid disease, including cancer. So radiation is serious. We take it serious. We monitor the levels of exposure through using sensors on everybody's lead. And everybody has the best lead, and it's monitored every 6 months. We check the lead for any breaks in the lead, for any cracks, any areas of weakness, and we replace the lead when it is damaged. So we have a very, very intensive radiation protection program at Deuk Spine Institute, probably one of the most aggressive there is in the country, because I have somebody in charge of it who is really smart and really cares and does a great job, Monica, okay? And we take it serious. Yep. So hopefully that answers the question. So it's a combination of shielding from the machine, a combination of reduced use of radiation from the machine or limited use. It's a combination of special shields on the operating table for certain procedures to minimize exposure to the staff and the patient. And it's a combination of using personalized radiation protective gear, including radiation shielding glasses and aprons and skirts. Did anyone know that I wear a skirt? Yes, I do. Dr. Deuk Majan wears a skirt. It's the only skirt I wear, but it's my leaded skirt, okay? And I don't wear skirts outside the operating room, but I do wear a skirt. Maybe some of you have seen me in a skirt on some of my videos where I'm wearing the lead. But that's being responsible and respectful of radiation. I hope I answered the question. I don't know if I did, but that was the first time we've gotten a radiation question, and I really appreciate the viewer for asking it. Next.
There are no other questions currently.
All right, so I'll talk a little bit more about radiation. We don't use a lot of radiation for this surgery, for the Deuk laser disc repair. We use very little. I would say we probably use, how many seconds of radiation do you have on that machine? 46 seconds. So under a minute. So typically we'll have about a minute's worth of radiation, which is very little. I remember reading about radiation exposure as a resident in most spine surgeons and most spine procedures, and they would have 10 minutes of radiation for a spinal fusion. So I was really concerned about that as a resident. I started looking for ways to minimize the amount of radiation exposure, even in training, as something that nobody else was doing. And we're almost done. We have less than 5 minutes. Less than 5 minutes. You're welcome. So when I got out in my own practice and I bought my first fluoro machine, we now have, I think, 4 or 5 fluoro machines. Each one of them is about a $160,000 machine. I was very careful to make sure I bought high quality machines that protected the patient and the staff from excessive radiation exposure. What do I mean by that? Well, it turns out the older machines, the less expensive machines, leak tons of radiation. They give you an overexposure of radiation. You're supposed to be getting a small dose, but they blast you with a massive dose because the quality control, the mechanisms of restricting the amount of radiation are not well developed in that machine. They're not working properly in those older machines. They found that the old CAT scans, for example, would give patients a massive dose of radiation. And they actually took them offline and stopped using them. But this was only about 10 years ago they figured it out. And patients were getting exposed sometimes to 100 times more radiation in one CAT scan versus another. 100 times. I mean, that's crazy. So they did away with the older, cheaper CAT scan machines, and most everywhere now you go, you have one of the newer models, and that's primarily because the rules required facilities to remove those CAT scan machines that were producing too much radiation and replace them with better machines that had better radiation control. So yeah, I take radiation very seriously. It scares the hell out of me. The worst cancers in the world can be from radiation exposure. So things like osteosarcoma, chondrosarcoma, thyroid cancers that are malignant. These are cancers there's no cure for, especially osteosarcoma and chondrosarcoma. Myosarcoma, which is a muscle cancer. They all happen in people with high levels of radiation exposure. So radiation is scary, and it needs to be respected, and it needs to be there need to be mechanisms put in place wherever you go where the radiation is highly controlled and minimized to the greatest extent possible. And that's what we do at Deuk Spine Institute. So I don't know who asked that question, but very insightful, and I appreciate it because I haven't talked on this topic before.
Oh, that's really awesome.
2 minutes?
It's just recovery phase. So
Yeah, we're around that painful.
take your time. Take your time.
We're on that painful disc, part of the disc. We're just about done. You're seeing some epidural fat at 12 o'clock, and we're in the last part of his herniation right here. It's the stubborn part. Looking good. Grab her.
So the strength training helps doctor here.
Yeah.
Okay, it's okay. It's okay. It's okay. You are
Just.
doing awesome, Austin. Are you okay there, doc?
I'm fine.
Okay.
Just about done here.
No, no, as long as you're
Yeah,
okay.
we're good.
Okay.
We're good. We're good.
It's okay, sweetie pie. It's okay. It's okay. It's
Yeah.
okay. Just relax.
All right, take that. We're done.
Operating room.
Yep.
All right, so please.
We are just finishing up. Everything is good. Dr. Deuk did a terrific job.
Scope off.
Document the energy graph, please. Total energy is 26. All right. Just document and yeah,
No
we
worries.
later.
No worries.
And
Can you open your mouth? Open your mouth.
total energy was 26.99. For the left, it was 23.98.
Pressure.
For the right, it was 23.10.
Did I tell you I'm going to Annapurna surgery?
Yeah, you told me.
Yeah.
That's awesome.
You have a great memory, doctor.
I mean, I'm a neurosurgeon. I'm supposed to have a good
What's
memory.
your IQ when you were...
I never tested my IQ.
Your son is amazing for his age.
Yeah. Thank you.
Oh, he's very mature.
These can turn off soon. Yeah.
What a great role model that he has. And he's
I try.
He's only 15.
15. He just turned 15.
It's okay. It's okay, Austin. Austin. Sweetie, just relax. You're doing great. Okay?
Everything's good.
Everything
So I'm just putting a little pressure on his
very
paraspinous
important
muscles.
to stay still, okay? We don't want you to fall, okay?
So the only place there'll be bleeding is going to be from the muscles. Just lay still. You're doing great. Lay still.
Lay still. Lay
Lay still. Everything's okay. Lay still. Lay still. You're doing good. Surgery's over.
You can bring the stretcher, is it?
Yeah.
It's okay, yeah.
All right, folks. So we've got these 2 incisions. You can see how small they are, 7 millimeters. Keep a little pressure for another minute.
There you go.
Just lay still.
Okay, sweetie. Lay still. Lay still.
Come on over and just help Luis in case he needs it.
Okay, and on together. Okay, sweetie.
Just lay still.
Very still.
Let him wake up a little more before you put the bandage on.
Given him anything at all.
Yeah.
He's actually opening his eyes.
Yeah, I just want him to be compliant
Yeah.
before you move away, Luis. So just stay there and holding him.
Hey, sweetie, come.
I've got a Raytech off the field. It's in the garbage.
Use your fast.
All right, folks. I'll take some more questions in just a few minutes. I'm going to head over to the conference room and I'll answer questions for you, okay? This would be a good time to type them up.
Do not move your legs. Do not move your legs. You are doing awesome. Stay very, put your arms up, okay? I know you're,
I'm going to call EBL 8 mil.
okay, sweetie? It's okay, give me some good deep breaths. You're in the operating room still, okay, sweetie? Don't move. You're gonna fall on the floor, okay? Squeeze my hand, squeeze hard.
We have the gurney, guys. It's in. Let's get it in. Dr. Kelcarney called for it, so I want it here.
What's that?
You want the gurney. I just told them to get it. Yep. All right, I'll be right with you, folks.
All right. Thank you for joining us for the post-op Q&A. One of our viewers from Twitter asked a question. Do fusions always lead to future back pain above or below the fusion, or is there a way that we can avoid it?
Okay, first of all, Dr. Deuk here with you, and we just wrapped up a two-sided, not two-level, one level. And the level, when we refer to a level, we're talking about the disc. So we did a one level, L5S1, but both sides, so we call it bilateral. Laterality in Latin means side. Bilateral means two sides. So we did a bilateral Deuk laser disc repair, L5S1, and we have a question, as Sean said, from the audience about if you have a spinal fusion, are you always going to have pain afterwards, eventually? The answer is no. You will not have pain afterwards, eventually, as long as the surgery is done properly. Okay? If the surgery is done properly, and I'm going to explain what I mean by that, if the spinal fusion is done properly, then the chance of having pain above or below your fusion is about 20%. 20%. So if the spinal fusion is done properly, the chance of having pain after the surgery is 20%. And that pain comes from the facet joints above or below the fusion, or it comes from the sacroiliac joint. The sacroiliac joint. This is in the lower back. Okay? Now, if you do develop pain after a properly performed spinal fusion, it's usually in the facet joints, and it just requires a rhizotomy. Okay? Some people will have pain after surgery, right after surgery. Everyone has pain from the skin incision, from the muscles, and maybe a little bit of pain from the bone where the surgery was done. The bone pain goes away in 24 hours. The skin incision pain goes away in about 24 to 48 hours. It's the muscle pain that lasts for weeks. So once you get past the muscle, skin, and bone pain from spinal fusion, which usually takes a few weeks, if you still have pain after a few weeks, then that's going to be something that we need to investigate and find out what it is, because that's not coming from the fusion itself. So, safely said, if you've done a month of recovery after your fusion and you still have pain, there's something going on that needs to be addressed. It needs to be diagnosed, and it needs to be treated properly based on what the diagnosis is. The more common causes of pain after spinal fusion, once you've recovered, are going to be facet pain. You could have muscle pain, which is called a chronic strain or sprain, which needs therapy and reconditioning. You could have facet pain, which requires medial branch block, rhizotomy, and therapy. You could have sacroiliac joint pain, which requires injection of the SI joint with steroid medicine and therapy for that problem. So let's talk about performing proper spinal fusion. This is so important, I can't even overemphasize it to you. Most spinal fusions done by most spinal surgeons are done improperly. They are done improperly. I don't mean they're unnecessary. They may be necessary, most likely they are. However, I'm talking about the technique. There's so many different ways to do a spinal fusion that you'd have to say there are as many ways to do a spinal fusion as there are shades of red. Okay? There's literally almost countless numbers, countless possibilities. And I'll be perfectly frank and honest with you. If there's 1,000 ways to do a spinal fusion, 990 of them are wrong. They shouldn't be done that way. Because what they're going to do is they're going to create problems for the patient after surgery. For example, screws. Believe it or not, the length of the screw you use in a spinal fusion is important. Shorter screws have higher failure rates. The skinniness of the screw, the width of the screw is important. Skinny screws, higher failure rates. Okay? The size of the cage you put into the space where the disc was. Very, 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 very important. Most surgeons don't pay attention to it. They just stick a cage in that's easy to get in. But you actually need to stick a giant cage in, the tallest cage possible without fracturing the end plates. But 90% of spine surgeons don't know this, and they don't do anything to fix it. As a result of a cage being too short, the spinal alignment will be wrong, and as a result of the spinal alignment being wrong, the patient will develop adjacent segment disease, which is a problem above or below their fusion. That adjacent segment disease will require additional surgery. Okay? So what I'm trying to explain to you folks, and I could go on, literally, I could list 100 different things that the surgeon could do wrong in a spinal fusion. I don't mean mistakes. I'm talking about just bad technique. I'm not talking about a complication like, oops, I cut the nerve root accidentally, or oops, I punctured the dura and I have a spinal fluid leak, or oops, I infected the wound, or oops, I hit the aorta and killed the patient. I'm talking about, oh, hey, high five, the surgery went great. No, it didn't, because what you did was you failed to correct the alignment of the spine. Spinal alignment is the second biggest failure of spinal fusion surgery there is. The first biggest failure, and this is published not by me but by other surgeons that are very knowledgeable from years ago, the number one failure of spinal fusion is a failure to adequately decompress the nerve roots. So there's spinal stenosis that exists and the surgeon ignores it or doesn't treat it properly, and so the patient has nerve compression and nerve damage and problems with their nerves, with weakness, numbness, tingling in their legs, feet, etc. So the number one cause of a surgery, a fusion, to go bad from the surgeon's error is failure to decompress adequately. The second most common problem arises from the surgeon who fails to put the spine in proper alignment. So what's proper alignment? Well, there should be minimized to no twisting at that segment you're fusing. You need to untwist the spine, so you have to fix the scoliosis at that segment you're fusing. There should be no kyphosis at that level. In other words, you should create lordosis or maintain lordosis, which is a curve backwards at that level. And number 3, you should try to fix listhesis, which is slippage forward, or anterlisthesis, or retrolisthesis. Try to fix the listhesis that may exist at that level. And then the last thing you want to do is you want to open the foramen as much as possible, and that requires a big cage in between the vertebral bodies. So as long as spinal fusion is done properly, and I mean maintaining proper alignment, decompressing the nerve roots, and treating all the levels. That's the third most common cause of failed surgery, is not treating all the levels that need to be treated. So as long as you do all those things, then the chance of having pain after a spinal fusion is 20%. And that pain is not going to need another fusion. That pain is just going to need some therapy and some needle procedures. So I think I answered that pretty completely. If you still have questions about it, feel free to post another question. What's our next question, Sean?
Our next question comes from a couple of viewers on Twitter who were discussing diets when you were discussing hiking up Mount Kilimanjaro. One of them asks, do you have any opinions on popular diets? Are there any that you've seen evidence of working, or are you on any yourself?
Oh, great question about diets. So it's funny you're asking this question. Let me tell you a little bit about myself. Before I was a neurosurgeon, I was a medical student, and I did my medical school at USC in Los Angeles. And USC medical school that I went to was about 125 years old around the time that I went, and very well established medical school. Great teachers. I had an incredible medical school experience, and honestly, I felt that USC prepared me so well to practice medicine. I'm very grateful. But let's rewind the clock back a little further. Before I was at USC in Los Angeles, I was at UC San Diego, University of California, San Diego. In my opinion, the best UC school there is and was at the time, which is why I went there. Graduating valedictorian of high school, I was able to choose which college I wanted to go to. I turned down Ivy League schools. I turned down pretty much any college that's on your wish list to go to UC San Diego. That was my number one choice. And being number one in my class in high school, and having being captain of the soccer team, and lettered in basketball and soccer and track and field and cross country and student government president and all those things, I was able, fortunately, to go to what I thought was the best college available to me, which was UCSD. Now, while at UCSD, I met a professor who turned out to be very special to me. His name was Dr. Paul Saltman. And Dr. Paul Saltman was a professor who taught basically nutrition. He taught nutrition. He was a nutritionalist, but at his core of his education, he was a biochemist. And I am a biochemist. I graduated UC San Diego with a degree in biochemistry and cell biology and another degree in chemistry. So I was a chemist from my training in college, which I think was a phenomenal place for anybody interested in medical sciences. Learn biochemistry. Biochemistry is basically the very basis, of course genetics as well, and molecular biology are the very basis of medicine. They're sort of the heart and soul of medicine. A lot of people don't understand that. But a lot of diseases begin because of aberrations or abnormalities that occur in biochemistry. So this question about nutrition really is a question about biochemistry. It really is. Because after all, what we eat gets broken down into small molecules that end up being involved in catalyzing biochemical reactions throughout our body and our cells and our tissues. And every tissue in your body that's specialized, like muscle tissue, liver tissue, brain tissue, kidney tissue, they have specialized functions of doing certain things for our body. For example, the kidneys eliminate excessive water, they eliminate excessive electrolytes, they eliminate some toxins, right? That's their job. And they have other functions too. They produce hormones, and they stimulate your red blood cells to develop in your bone marrow. So they have probably, it's kind of like a really good employee. Your really good employee has like 10 jobs that they do, and they're important jobs. So your kidneys are important, all your tissues are important, they all have jobs, okay? So nutrition is really about the biochemistry of tissues. So if you really want to support your body and be healthy, you have to understand the biochemistry. You have to understand what things that you eat that change the biochemistry of what goes on in your body in a negative way, and what things you eat change the biochemistry in a positive way. So my best advice to you with nutrition, because it's a very long discussion, is I want you to Google Paul Saltman, P-A-U-L Saltman, S-A-L-T-M-A-N. He was a PhD, and he was a faculty at UC San Diego. He's written books on nutrition. As a matter of fact, the Japanese government, the country of Japan, hired him to create the Japanese diet, the diet for Japan. And this was back when Japan was like, dominating the world economy, back before, obviously before China even was being talked about, or India. This is back when Japan and the Japanese people were very, which they still are, very highly productive, obviously, but this was when they were kind of the focus of the world in terms of producing things, high quality things. So and what I'm saying to you is, this is the country, they tapped Dr. Paul Saltman at UC San Diego to develop their Japanese diet for their country, the recommendations. That's how highly esteemed he was held by the world when he was alive. And of course, he was a student of Linus Pauling. Linus Pauling is an exceptionally famous biochemist, a brilliant biochemist. And so rather than me trying to tell you what's a good nutrition for your body, I would recommend you read Dr. Paul Saltman's book and books. He has more than one, and you can probably find them on Amazon and read up on them. So that would be the best advice I can give you about nutrition. Well, that was our last question for the first surgery, and we have 2 more surgeries coming up. Our next patient is having Deuk laser disc repair done, right approach, L34, L45. They have herniated disc at L34, L45, and they're having back pain and leg symptoms down their right leg, including pain and numbness and tingling. So we're going to be treating the back pain, and we're going to be treating the leg symptoms, and hopefully eliminating these problems for this patient with the Deuk laser disc repair procedure. I expect to get both discs treated with 1 incision, 7 millimeters, and this patient will also get a rhizotomy during the surgery because they need their facets treated. They have facet pain as well as disc pain. Remember, pain coming from a disc is called discogenic. Pain coming from a facet joint is facetogenic. And about 50% of patients have just discogenic pain, and the other 50% have discogenic pain and facetogenic pain. So we do both the Deuk laser disc repair to fix the disc pain, and we do the facet rhizotomy to fix the facet pain. All right? So just a little pearl of wisdom there for you. Hopefully you'll be available to watch the next surgery, but if not, that's okay as well. We'll continue broadcasting our surgeries live from Deuk Spine Institute around the world, free for educational purposes, to teach the world about fixing back and neck pain, curing back and neck pain, which back and neck pain are cured every day at Deuk Spine Institute.